Good evening, everyone, and thank you for joining us for another International Dermatology Education Foundation educational series. Unfortunately, tonight we do have a technical problem where our cameras are not working, so you will not be able to see Dr. Neal Bhatia's handsome face. So unfortunately, we just be seeing the slides. So our tonight's program is on Jublia. It's a scientifically designed topical treatment for toenail onychomycosis. Jublia Efinaconazole topical solution 10%. I'd like to thank our supporter tonight, orthodermatologists, that made this program possible. Before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial information will be displayed. If you're having technical issues, please submit your question in the questions pane on the right-hand side of your screen. And at the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate if you can fill out this very short survey. Also, within 1 to 2 days of the webinar, a certificate of attendance will be mailed to you. Please submit your questions using the questions pane on the right-hand side of your screen. At the end of the session, we'll try to answer all the unlabeled questions. I'd like to tell you a little bit about IDEF, International Dermatology Education Foundation. It is a non-profit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. As you know, we started our mission during COVID, and we are moving on. We have done several programs now. We almost have a program once a week, sometimes twice a week, as you attended the one we had last night and tonight. Now, also, you can stay up to date with our webinars at either IDEF/Derm in Instagram or Facebook as well. And please visit our website at idefeducationalseries.com to register for upcoming educational events. So tonight, we are very lucky to have Dr. Neal Bhatia, who is the Director of Clinical Dermatology, Therapeutics Clinical Research at San Diego, California, who happens to be one of my best friends in dermatology, and he's going to discuss a scientifically designed topical treatment for toenail onychomycosis, Jublia, topical solution 10%. As I mentioned, unfortunately, we do not have the cameras working because we have so much attendance. I think you guys broke my cameras. We have more than 2,100 people attending this webinar tonight. So I'm so proud to present a good friend of mine, Dr. Neal Bhatia. Neal, take it over.
Yeah, thank you. And it's a good thing for the audience. There's no cameras, otherwise they'll see my messy office and my messy hair. So it's good. But thanks to the 2,000 people attending, I feel like Taylor Swift with all this audience. It's great. I'm going to be giving the overview of toenail onychomycosis, like Dr. Kircik said, and we're going to move forward with the presentation. Again, this is sponsored by Orthodermatologics. I'd like to thank them for asking me to participate as well as for the slides. We actually were trial site before this. This was before I was working here, but they did the trials on Jublia, which was a really nice trial to do, very well done, and some good data that came from it. So again, this is me being with my disclosures, and I've done a lot of consulting work with Ortho as well as some trials, and it's always a privilege to work with them. So let's talk about nails first of all, and as a whole. You got to understand the physiology and the anatomy of nails to really understand how do topicals work, as well as understand where the fungal burden is. Because even though most of what we see clinically is on the nail plate, which is the top layer, obviously the nail bed is where the scene of the crime actually occurs. You can see the discoloration, thickening, and the separation of the plate from the bed. But the fungal burden, the hyperkeratosis that develops, the influence on the nail plate all comes from the nail bed dystrophy. Even more so is the risk of secondary infection, the pain that comes with elevated toenails, and obviously, of course, the aesthetics and the visual part of the toenails that can be very disturbing. It's also the risk of further dermatophytosis, if you will, further seeding of the skin to get tinea pedis, tinea cruris. And of course, these are the major fungal specimens that you see: Trichophyton rubrum, Efinaconazole, these are the main ones. Tracheophyte metacrophytes is also a pretty common one as well. And then you see some non-dermatophyte, pathogens that can also cause part of that alternaria and some of the other molds that get into the nails. Part of the problem is, again, the structural components, they have a big influence on the way that the active ingredients get to, again, the scene of the crime of the nail bed. The plate has about 25 tightly bound keratin layers. Layers of dead flattened cells, which are filled with alpha keratins, and of course they're cross-linked. So again, you need some affinity to keratin. Again, you need a little bit, but not a lot. Otherwise, you're not going to penetrate. You're going to get bound by the keratin. The other part of it is, again, a hydrogel that has a very, again, concentrated very concentrated hydrogel to it in the nail, right? That's going to allow for small molecules to permeate. So again, there's a difference between penetrate and permeate. You don't want to permeate all the way through the nail, but you want to get penetration into where the nail is actually doing its job. So the two most important physiochemical properties that you'll see are, again, the low keratin affinity, just enough to get into the binding and have its mechanism, bound there, as well as the high hydrophilicity. And that's really important. You really don't want a lot of lipophilicity. You want more hydrophilicity as the nail is, again, more concentrated as a hydrogel. So the therapeutic ladder has been very interesting over the years, actually more than decades, where we were mainly dealing with oral therapies. We had very few topical therapies that actually did penetrate, or they were used for other conditions. There were some lacquers, some gels, some other topicals that were involved. But now you see, especially on the pediatric side as well as the adults, when again we're dealing with 65 and younger, or we're dealing with kids, topical efinaconazole, as you see, has a very strong role, either as monotherapy or in combination with oral terbinafine. And even more so on the right side, when you're dealing with diabetics, patients with peripheral vascular diseases or other meds, you really want to take into account how much topical therapy you're going to have to deal with in terms of duration and its actual use. But really, it again goes back to the question of how do we treat? We treat top down and we treat inside out when it's more severe. You can get by with maybe a couple nails by treating topically, or if it's milder. But the vast majority of patients who are a little more severe, who have multiple nails, who have other issues with potential tinea pedis developing, they tend to also get on oral therapy, which is again very important. The dermatophytoma is sometimes again a finding that you'll see. These were not part of the phase 3 trial, but the clinical recommendation for their treatment is again also topical efinaconazole solution. So again, efinaconazole topical solution 10% is Jublia, indicated for topical treatment of onychomycosis, which is otherwise known as Toenail Onychomycosis. And again, due to trichophyton rubrum and T. metacrophytes are the most important species there. Main thing is it's for topical use. You don't eat it. You don't use it in your eyes. You don't put it in the genitals. And more importantly, is if there is any issue, you want to talk to your healthcare professional, whoever prescribed it for you. We'll talk about some of the adverse events in the later parts of this. Most important adverse events, which we'll just go over now, again, were mostly application site issues. There were ingrown nails that, again, were difficult to treat, and they actually developed during the trials, but again, that's considered an adverse event in the trial. And then, of course, some experienced some mild application site pain, which we can show how that can be actually avoided or else even mitigated. And then it can be used in pregnancy if the potential benefit justifies the potential risk to the fetus. Should be used in caution in patients who are lactating. And again, patients under 6, their safety has not been established. But as we saw from the algorithm, the pediatric patients who develop onychomycosis should be treated accordingly. That being said, to reach the scene of the crime, the site of infection gets, it's very important to, again, have the right vehicle, but it's also important to have the right active ingredient. And efinaconazole is an azole antifungal, which we know has, again, low keratin binding. It's hydrophilic, and it gets, again, the activity against the fungal pathogens, which is very important. Again, if you remember, the terbinafine family works on squalene epoxidases, a different enzyme where the azoles work against the cell walls of the fungus. Again, the alcohol-based formulation allows for that active ingredient to penetrate and get into where it needs to go. The low surface tension allows for easy spread. And then, of course, the non-lacquer ability to spread is really good for the patient's use, as well as, again, not having a big buildup, no need for debridement or for removing that lacquer like we had with some other products once a week. But again, it's delivered with a nice brush applicator, which I'll show you how some of that works as well. More importantly is, again, when you're doing clinical research, we mainly look at the first toenail, the great toenail. And obviously patients need to come in without their nails painted. which is very important. But even more so, we measure from the proximal nail fold to the distal nail fold and the hyponychium, and measure the growth as well as, again, how much involvement of the fungus is actually seen in the nail plate. And as you see, the baseline involvement for this patient, for example, was 35% of the nail, and that's marked as you see from the marker. And then distally, you look at the first application and you see how much in the fluorescent photography, how much of that active ingredient actually penetrates, right? It actually gets to where it needs to be in the nail. And then after the second application, it's continued and its cumulative effect is there, but it's not, again, building like a lacquer would. More importantly, as you see the post clipping, to see, again, how much activity of the efinaconazole solution that's radio labeled is actually getting into the areas of the nail where it needs to be. So again, that distribution below the nail plate and into the air gap is what we're looking for as far as where that's actually having its effect. As I mentioned before about the keratin affinity, that's real important because, again, we don't want the entirety of the product to be bound by the keratin, right? Because otherwise it's not going to get to where it needs to go in the nail bed. But it also, we don't want it to permeate all the way through and not get in, not stay in the nail bed. It's actually going to go past that time. Even more so, again, this in vitro study examines the amount of free drug levels of antifungals after incubation in that 5% human keratin suspension. And as you see, there's a significantly lower affinity to human keratin than the other products that were used in the past, such as cyclopirox lacquer, for example, which was Penlac. So again, that difference means that there's more active ingredient getting to where it needs to go, and it needs to actually get there, without the impediment of all that keratin. That, again, as we know in onychomycosis, there's a lot of hyperkeratosis, which means there's a lot of keratin. So how do we get to where it needs to be? Well, again, it actually was studied with nail polish, right? And you can use gel nail polish on the toenail at 24 weeks, as you see here. Patients were actually studied. They were using 2 different brands and over 30 different shades of nail polish. They applied Jublia once a day for 6 months, 24 weeks. And as you see, there was a significant amount of mycological cure, right? Which is really what we want. But again, the complete cure, which is tough because it's mycological cure and no nail involvement, that's a very high bar, right? That's why there's only about 44%, as you see here. The difference is, again, patients want their nail back. What we have to remind them is that we want to get rid of the fungal burden first, and then the nail itself will grow as it takes time, right? But in clinical research, we don't want to label something that says, oh yeah, it only works 44% of the time. But our definition of work is get rid of the fungus. But again, the high bar of having the nail plate, regenerate to or regrow to where it has zero involvement, again, that takes time. It also takes a lot. It's basically dependent on the patient's health. If there's trauma or predisposing cardiovascular issues or peripheral vascular issues, that's going to be an impediment to new nail growth. But you see some of the nail pictures as you see, as you go from left to right, you'll see a lot of improvement in those nails as well as where they all fit in the paradigm of what's complete and what's clinical cure. Oh, sorry, let me just go back one thing. You see that the nail polish duration, how long it was worn, the quality of the nail polish, how long it was added to dry, or the texture of the nail with the nail polish on. None of these were affected by the measurements in the trial. Okay. Now again, this was a trial without a control arm compared to the pivotal data, right? This is very different than just studying against vehicle, but this answers a lot of questions about can patients wear nail polish. So I think that this study was real important to put some of that misconception out there. Now again, reaching the site of the infection is important. Again, the nail thickness, however, shouldn't be an issue, right? It's not like warts where you can pare down the callus or anything else. It's outside of podiatry, dermatologists don't have a lot of tools, outside of a curette perhaps, to really tear down some of that hyperkeratosis and that retention keratoderma. But that being said, in this study here, you look at 10% solution applied daily for 28 days, and they looked at the amount of penetration, and you see the escalation at 2 weeks to 4 weeks, a little bit tapering off at 6 weeks. And again, you see on the right side of the graph, again, the impact on the gray toenail and the second toenail, how much of that active ingredient was still measured, right? So again, the extent of that penetration was very important. The bottom line is, again, it was not affected by any other disease, and it was not affected by nail thickness. So that's real important to recognize. Now, again, the issue of the nail growing back is going to be something that we'll see variable results with patient, but that also, again, in the real world, is dependent on compliance and everything else. Okay, let's talk a little bit about some of the safety and efficacy numbers that we saw in the two phase 3 trials. And as you see, there were a lot of patients studied, over 1,655 patients. They were randomized 3 to 1, where 3 out of 4 patients got active drug and 1 got the vehicle. And remember, in dermatology, we don't say placebo, we say vehicle, because the vehicle should still have some impact, whereas placebo will have none. Now, there's 2 parallel 52-week multi-center randomized trials, double-blind, of course. There were men and women 18 to 70, so the PEDS patients were not in this trial specifically. And then, of course, they had to have more than one, or one or greater, more than one great toenail impacting 20% to 50% of the toenail without dermatophytomas, or the matrix involvement, which is again told by the lunula. And again, they have to have some uninfected length, which is 3 millimeters or greater from the proximal nail fold, so you can have a measurement. More importantly, is the thickness was less than 3 millimeters. So a lot of different parameters to keep in mind. But these were all measured by the study investigators based on the inclusion and exclusion criteria for them. Now, again, they were applying once a day for 48 weeks. They were evaluated at week 12, week 24, week 36, and week 48, which is very realistic. And many of us in the real world would probably not see these patients back at all. We would just tell them, go to work. I'll see you back next year after you apply for all that time. Because, again, sometimes time is the only prescription you can't write. But at the same time, patients need to understand this is not going to be something that gets better overnight. It took them quite a while for that nail to change. It's going to take some time for things to improve. But at the same time, the complete cure is measured as 0% involvement of the nail and complete mycological cure, which is a negative KOH and a negative culture at 52 weeks. The secondary endpoint, again, is mycological cure alone with less than 5% of the nail involved, or even treatment success, which is considered less than 10% of involvement. Again, we're not going to kick patients out of clinic and say, oh, sorry, you still have 10% or less of your nail that's involved with fungus. This is still something we'd say, let's keep going and, let's celebrate some of your improvement. But at the same time, in the trial, if they don't meet those endpoints, they're considered failures of the treatment. Now, notice a couple of things about both study 1 and 2. Obviously, their design is the same. Their active treatment went up to 48 weeks with a 4-week observation period. But notice the spike right around 24 weeks of, again, how much improvement the patients were starting to see during that active treatment period, as well as the number of subjects that were achieving those complete cures, right? There weren't too many at week 12, but definitely starting to see some significant number increase by week 36, and definitely see that spike between weeks 36 and 48, how many patients actually were measured as having complete cures, okay? And again, you see the photographic improvement of that patient who had over half that nail plate involved. Already by 24 weeks, there was significantly less involvement, almost to the edge of the distal part. And then by 52 weeks, the patient was clear, which was great. This is, again, another good example of a complete cure. You see how much significance of the involvement there was both in the center as well as on the right side of the patient's nail. And again, by week 24, again, a lot of improvement on both sides. And by week 52, there's a little bit of transverse ridging there on some of the plate. And you see a little bit of a darker line on the top. But again, those are completely brand new nails, which is great. That's what patients want. But again, our goal is to get rid of the fungus, which again, if patients had trauma to their nails, if they've had long-standing peripheral vascular disease, their impact of growing a nail plate is going to be somewhat tampered. But at the same time, you see how much evidence there is that there was eradication of the fungus. The mycological cure at 48 weeks was almost 55% in one, 53% in the other. And again, that's a negative KOH and a negative culture of that toenail. So even if the nail, I guess regardless of the appearance of the nail, you still see all of that improvement under the microscope, which is important. And again, I look at that cumulative effect, whereas again, at 48 weeks, you really start to see the spike that developed as early as 24 weeks. But here again, you see in the study, again, 24 weeks for both, that's when you start to see more gradual ascent of those improvement numbers of the patients who achieved either a complete or almost complete cure at 52 weeks. And these are numbers, again, this takes time. It takes a little bit of discipline on the patient's part, but this is the motivated patient who's going to get their nails at least to be not only free of fungus, but to be improved clinically. And then, again, the application site reactions were things that we assayed for in the trials, right? We always do that with any topical agent. We look for any evidence of dermatitis, any potential irritant that develops, any application site vesicles, and then, of course, the subjectivity of pain that's reported. The ingrown toenail issue is, again, it's something that patients were noticed to have. Whether that's a phenomenon of the treatment or a phenomenon of the disease is independent of it being reported as an adverse event. And again, 2.6% of the Jublia patients and 0.2% of the vehicle patients discontinued prematurely because of any adverse events. So again, there's no issue with cytochrome P450. Obviously, this is a topical agent with, again, at their therapeutic concentration, there is no evidence of absorption. But it's also, again, the question of how much time are you going to use it for. And again, in the study, that was 48 weeks with a 4-week observation. This was, again, now looked at 72 weeks. And again, that extra, however many weeks, 28 weeks that you want to look at, or 24 weeks, excuse me, that shows, again, that the treatment of 1.5 years really adds to the amount of treatment success patients, the amount of patients who achieved a complete cure and the mycological cure, as you're seeing those numbers really start to improve, and again, at that final assessment. So if you notice where they are at 48 weeks, look at them further up, and at 72 weeks, you'll still see a very significant amount of improvement. So again, my thinking is if I'm going to use these patients, if I'm going to get patients who are motivated to use it, I would have them go at least for 1.5 years based on some of this data. I think that's real important. But the tolerability profile, again, about 5% developed a contact dermatitis or some sort of application site irritation. Some developed application site erythema. But again, we're just doing topical, right? There's no risk, with pills that we see with any hepatic issues, any issues with their CBC, any drug interactions. This is, again, something that patients have to do from the top down, and they're getting, regardless of the thickness of the nail or any concomitant issue, they have the ease of putting it on. But again, it has to be something that they can do. Now, of course, one of the biggest questions is, okay, what about patients with diabetes? What about older patients? What about patients who had onychomycosis forever, right? So these were 3 separate sub-studies that were taken on, and they looked at the number of patients who, again, had issues with paresthesias, for example. Were they a little too heavy? That might have made them, a little bit less likely to get to their feet. Did they have cataracts so they couldn't, evaluate their feet, right? And then, of course, the peripheral circulation being compromised is a big issue also, because that's going to slow down the improvement of the nail plate texture as well as its clinical improvement. But we do know in diabetes, there's a risk of onychomycosis. Again, that can actually lead to amputations, can lead to recurrent cellulitis, it can lead to other infections, and a lot of antibiotics where patients, again, may not be at ease for using that. Taking into account now this, again, some of this data where they looked at 1,200 patients, they studied them either again against vehicle versus Jublia, and again, how many patients had diabetes? About 13%, and 18% of the patients said they didn't have diabetes, right? Even more so, again, there was no difference in the Jublia treated patients versus those who didn't have it, right? So diabetes or not, the response is still going to be the same to the therapy. So this is where, again, you take into account the patient's overall well-being, number of nails involved, and again, how many patients need that treatment, right? And again, very similar to some of the other adverse events, contact dermatitis, irritation, erythema. These are small numbers, but again, these are just things we want patients to be aware of. And then, of course, the phase 4 study that was done for peds, looking at 6 and up, they studied 60 patients ages 6 to 16. They at least had mild, toenail involvement, because again, that's what you'd expect. Onychomycosis in one toenail, again, at least 20% of that toenail involved. Again, no evidence of dermatophytoma, no evidence of matrix involvement, things like that. But again, the PK of Jublia was an important part of that study. These were done in 12 to 16-year-olds. Obviously, the blood draws are a lot easier in those patients, and they had over 50% of the nail involved. So again, a little bit different for criteria for that subgroup, but that was also, again, to prove pharmacokinetics, which is real important, because if you can prove that there's no absorption to the bloodstream, it's going to allow parents to be a little bit more accepting of the treatment. And again, this is where, again, a couple adverse events here and there, nobody with serious adverse events, nobody had, again, any other withdrawals because of it. And again, the ingrown nails were a part of the phenomena which were, again, reported as adverse events. But as you see here, excuse me, look at the numbers again, 40% complete cure at 52 weeks. I mean, again, you see that spike around 24, 36 weeks. You also see, again, look at the number of patients who, again, had that, achieved that mycological cure. Again, I think I said this is really, again, at 48 weeks is great. I would, again, probably say I would keep continuing the treatment for at least a year and a half in a lot of these patients. So I think that's a good overview. It answers a lot of questions about who's a candidate, who's going to respond, and more importantly, what's going to get in the way. What we saw was thickness of the nail doesn't get in the way, nail polish doesn't get in the way, presence of diabetes, presence of any other concomitant issue. Most importantly is this is a topical treatment without any drug-to-drug interactions, which is real important. So the safety is there for patients, safety for PEDS patients, and even more so just thinking in terms of who's your right candidate. I think the motivated patient who really wants to treat their nails is going to do well, with this, treatment. As again, we're treating top down, but we also know the active ingredient gets to where it needs to go. So again, demonstrated safety profile in PEDS patients 6 to 16. The azole mechanism, we understand its role in treating fungal diseases. And of course, again, the presence of nail polish in vitro, first nail therapy, again, first line nail therapy, if you will, for mild to moderate. No treatment differences based on any disease duration or coexisting diabetes. And of course, the most common adverse events were mainly topical and application site from there. There's some good information on jubliarx.com. And of course, most commercially insured patients will pay no more than $75 for Jublia, which is great. I send it to a specialty pharmacy. The copays are very little. Patients, at least I know they're getting the active drug that I want. They're not getting substituted. And again, if the drug is covered, the patient will pay as little as $0 when the patient is commercially insured. When it's insured but the drug is not covered, the patient will pay as little as $65. And of course, the deductible would be high or anything else. They'll pay as little as $75, which tells us a lot. Again, that's not for any government plans, not for TRICARE, Medicaid, Medicare, anything else that goes along with it. But there's a QR code, or you can go to OrthoRx Access to gain some of that as well. Prior auths, again, are dependent on some of the paperwork, right? You want to make sure that you're correctly coding and documenting that there's pain, how long the nails have been diseased, what other concomitant issues there are, what other concomitant medications there are, and the patient preference of wanting to not take a pill is very important. You also want to have some objective measure because, again, onychomycosis can be misdiagnosed very commonly by the untrained eye. So doing a KOH is actually, again, you can bill for that obviously in the office, but it's an important backup to the clinical exam. And I think it's something that just should be very easy to do in the office. Just take a little microscope slide, or you can take a little 15 blade, get some of the debris, let it sit for about 5-10 minutes, go see somebody else or do something else, and then make sure you evaluate the KOH and have somebody sign off on it, if you will, as well. And then, of course, the ICD-10 code is B35.1. That's important to make sure you use the right code because, again, that's going to be important for reimbursement as well as for not only getting your work, but getting the right drug. And again, documentation of treatment failure with an oral is also real important. That helps quite a bit. Okay. And again, many prior auths are denied. Again, you want to make sure you're documenting correctly. You want to make sure everything is being done to support your diagnosis in the lab. And then, of course, making sure that everything from there goes along with, again, supporting your diagnosis and supporting your rationale for therapy. Okay. And then, of course, again, you don't want to miss submitting that KOH. You don't want to miss supporting all the supporting documents as well. So that is all I have. I think Dr. Kircik and I are going to have a little discussion, but that's all I have for the slides. I hope that was informative, and I hope that it definitely makes some sense for everybody. So, Dr. Kircik, I'll call you back, and we can summarize a little bit.
Thank you, Neal. That was great. Sometimes we need to be reminded all those things. Jublia has been around for a while and has been a great help, but sometimes we forget, right? So this was a great reminder. And we do have some questions and we have some time. So one question actually I had, and you did a good job explaining, but I think it might be helpful, this treatment success story and about the clinical cleanness plus the fungal culture plus the KOH. It really makes it a difficult bar to get there. Tell us a little bit, how does that exactly work?
Well, I think the previous medications we've had, they were good attempts to prove to patients that you could treat topically. But many of the skepticism behind some of the clinical research numbers led to kind of a downfall of their prescribing. But to think about who's the right patient, you really have to again go back to the way I phrased it about treating top down as well as treating inside out to get rid of the fungal burden, as well as remind the patient where is the disease. It's underneath the plate, even though what they see is the disease nail plate. So I guess to answer that pivotal part of the question is it's more about how much time are we spending with patients on their understanding of the disease first, and then trying to get them to understand the rationale of treating topically. It's very similar to what we deal with acne when patients are not using the topicals and they're relying on antibiotics alone, or they're not understanding that the rationale for therapy is complete from inside out and top down. So I think that's really on us to have that conversation. I think it's also on dermatologists to remind the patients that this is a dermatology disorder. We don't want to just turf these off to the podiatrists or anything else. We want we have to be able to be the ones in charge of taking care of things, because a lot of the consequences of undertreating are dermatological issues. They're not podiatry issues.
Great. And I always say vehicles matter, and certainly here vehicle is playing an important part. So maybe you can elaborate a little bit on the important properties of the vehicle in Jublia.
That vehicle part of it, of course, I owe you $5 now for saying vehicle matters. But the pivotal parts are the twofold: the hydrophilicity of the drug, which is compatible with the, again, more water-based or the hydrogel nature of the nail, and so that a lipophilic compound would not do well in that environment, obviously. At least the ingredient. But the other part of it is the keratin binding, which has, again, you want that low affinity. It's kind of like a golf score. You don't want a high score, you want a low score, because if a drug has a high affinity for keratin, it's going to get bound in the nail plate and it's not going to penetrate to where it needs to go in the nail bed. And I think it's important to keep that in mind. So those are the really pivotal parts of how that works.
So that's interesting, right? Always, most people think the perception that you want a drug that has a high affinity for the keratin, but it's actually, that's not good, because it's gonna stay just on the nail plate and it's not gonna go, right? That's the whole point.
Exactly. So I think that's really important to get that across.
How about adverse event side? You did mention this is a topical, of course, it's not an oral. So I always see dermatophytoma when we look at the adverse events of topical agents. And then how about irritation, contact derm, anything?
Yeah, I think anyone who does trials knows that there are going to be patients who say, oh yeah, it burns when it goes on, it hurts when it goes on. Keep in mind, again, any diseased nail is already going to have symptoms that go along with pain and irritation. So some of that just may be the application of the liquid to an already painful nail, but some of it may also be the sensation of the vehicle and it hitting the skin. So we talk about this with rosacea, with eczema, that patients will say, well, yeah, this burns when it goes on, it stings when it goes on. But it's also because that diseased skin is hypersensitive. So I look at these low numbers and I say, well, okay, these are not striking, that these would be dose limiting for me, or not, make me not want to prescribe them. If these were like 50%, application site irritation, I'd be like, wait a minute. But these are rare cases especially in the high numbers of patients that were enrolled. So I'm not overly concerned about it. I think the other part of it is it's technique dependent. And the Jublia website has a very good application video that I refer patients to, and I say, go watch the video on how to apply it, and I think that'll take a little bit of the angst out of the equation.
Perfect. Thank you so much. I think we're all done with our questions, and we're lucky enough to be able to finish early tonight and give some time back to our audience. More than 2,000 people we had. I'd like to thank orthodermatologists and thank you all for your support, as well as all our audience here. So now that we are done with the Jublia program, I just want to mention our next program is on July the 23rd. We have Dr. Brett King, who's going to discuss with a patient of his the burden of alopecia areata, a patient journey. So I hope you guys all join us on July 23rd at 7 p.m. Standard Time. I thank you so much, and thank you, Dr. Bhatia, for that very eye-opening reminder about Jublia. Thank you, everyone, and have a good evening.